Greetings, dear learners. We were learning the carbon monoxide poisoning. Under that, we learned about the clinical features, their properties, and the different mechanisms of actions. Continuing with the same, we will be looking at the remaining features in case of the carbon monoxide poisoning. The classical signs seen in case of the carbon monoxide poisoning, they are rarely seen in the clinical practice. They are the cherry red discoloration of the blood and tissues, including the skin, that occurs in the 2 to 3% of cases. We already talked and saw the picture of the cherry red discoloration. Then the cutaneous billet or the blisters are also the features seen in the case of carbon monoxide poisoning. They appear within 24 hours of the exposure and mainly on the palms and the soles of the person. High risk group for the carbon monoxide poisoning include the infants due to the high respiratory and metabolic rates, pregnant women, the elderly, individual with the anemia or the hematological disorders, and those with the history of the heart or the lung disease are the more prone persons. Patients may experience post-carbon monoxide syndrome with persistent headache, nausea, weakness for up to 3 weeks after the exposures. Severe or the delayed neurological effect known as the interval form of the carbon monoxide poisoning can occur 48 to 72 hours after the exposure, including demyelination that we saw in case of the carbon monoxide induced encephalopathy in the central nervous system. Careful observation for the neurological deficit is the necessity. Symptoms of the delayed effects include the irritability, confusion, memory loss, gait disturbances, speech problems, visual losses, tremors, and the urinary incontinences. Physical signs may include the increased muscle tone, tremors, and the Babinski signs. These all features are seen in cases of the carbon monoxide poisoning. Additional to those we saw according to the concentration of the carboxyhemoglobin, different types of the features that are seen in the patients of the carbon monoxide poisoning. Then in case of the chronic poisoning with the carbon monoxide, patients may present with the headache, dizziness, confusion, intellectual decline, weakness, nausea, vomiting, abdominal pain, numbness or the tingling sensation, paresthesias, visual disturbances including hemianopia, papilledema and the retinal hemorrhages. High blood pressure and the hypothermia is another feature in case of carbon monoxide poisoning on chronic exposure. Cherry red discoloration of the skin, heart palpitation, worsening angina and intermittent claudication, increased red and white blood cell counts, presence of albuminuria, glycosuria, then permanent neurological deficit are common such as amnesia, apraxia, personality changes and the blindness. Then in case of the carbon monoxide exposure during pregnancy, carbon monoxide is teratogenic, affecting fetus more than the mother. It can lead to the brain damage, mental retardation, limb malformation, seizures and the stillbirths. Then to make the diagnosis of carbon monoxide toxicity, carboxyhemoglobin levels initially shall be measured and repeated every 2 to 4 hours until the patients improve or the level returns to the normal level. In the healthy normal individual, up to 5% of the carboxyhemoglobin level is considered to be normal, whereas in case of smoker, up to 10% of the carboxyhemoglobin level is considered to be the normal range. So it shall not. So when interpreting the results of the carboxyhemoglobin level, this shall be kept in mind. The carboxyhemoglobin level is measured using co-oximeter. Monitor cardiac function with ECG for signs of the myocardial damages like the ST depression or elevation and the dysrhythmias. Conduct a chest X-ray to look for the specific signs of the damage and the considered CT MRI if neurological impairment persists. Routine blood and the urine tests show the elevated creatine kinase level, lactate dehydrogenase, creatinine, hypokalemia and the picture of the hyperglycemia. These all parameters shall be monitored and the symptomatic treatment for them shall be given. Then the certain bedside test for the carbon monoxide poisoning is that dilute the blood with a drop of 10 to 15 ml of water. On dilution of the blood, it will show the pinkish discoloration. That is feature of the carbon monoxide contaminated blood. Dilute. Then another method is the dilute 1 ml of the patient's blood with 10 ml of the water and add 1 ml of the 5% sodium hydroxide solution. A straw yellow color indicates the carboxyhemoglobin concentration of less than 20%, while the pink indicates the carboxyhemoglobin concentration of more than 20%, and normal blood turns brown to this reaction that is indicative of no carboxyhemoglobin in the blood. Then coming to the treatment of the carbon monoxide poisoning. First and foremost measure is the remove the patient from the contaminated area immediately. Then administer 100% oxygen via a tight fitting mask or the endotracheal tube until the carboxyhemoglobin levels drops to 15 to 20%. Monitor arterial blood gases and the pulse oximeter closely. Mechanical ventilation with a small tidal volume may be necessary if the acute lung injury develops. Monitor cardiac and the respiratory functions regularly. Keep an eye out for the signs of the cerebral edema using neurological examination, CT scan and the fundoscopic examination. Manage raised intracranial pressure with hyperventilation, head elevation and mannitol infusion. Then if metabolic acidosis persists despite correction of hypoxia and the fluid resuscitation, consider the IV sodium bicarbonate, monitor electrolyte for the potential imbalances and correct accordingly. Provide supplemental glucose to prevent hypoglycemia. Provide supplemental glucose to prevent the hypoglycemia. Control convulsions with the IV diazepam and the phenytoin. So other measures are symptomatic measures. Most important measure is the oxygen therapy. Then treat the hypotension with the adequate fluid resuscitations using crystalloids. Address the brady and the tachyarrhythmias appropriately and initiate the vasopressure or the inotropes as needed. So as I told you, consider the hyperbaric oxygen therapy as an antidote for the carbon monoxide poisoning and administer the 100% oxygen at the 3 atmospheric pressure for 30 minutes followed by 2 atmospheric pressure at 60 minutes or until the carboxyhemoglobin levels drop below the 30%. In this way, the main method to control the poisoning with the carbon monoxide is the hyperbaric oxygen therapy. Then coming to the post-mortem finding in case of death due to carbon monoxide poisoning. In the cases of the examination of death due to carbon monoxide, you will find all the features of the asphyxia as we already discussed. Then the cherry red discoloration may be seen on the skin and on the hypostasis regions. Skin, mucous membrane and the nail beds exhibits a distinctive cherry red, that is pinkish discoloration along with the post-mortem hypostasis. Skin blisters, we already talked, cutaneous bullae are present on the wrist, interdigital surfaces of the fingers, knees, calves and the buttocks. Blood, the signs, that is the fluidity of the blood is increased in case of the asphyxial death. The same is seen here also. The blood remains the fluid even after the death. All the body cavities show the presence of the serous effusions. Lung is congested, displaying a cherry red discoloration and signs of the pulmonary edema. Soot particles may also be detected in trachea in cases of the carbon monoxide poisoning due to the fire. Cardiac abnormalities includes the petechial hemorrhages, myocardial infarctions and focal areas of necrosis with basophilia evident in the cardiomyocytes. In the brain, edema, necrosis, cavitations in the basal ganglia, particularly in the globus pallidus and the putamen. In the case of delayed death, punctiform and the ring-shaped hemorrhages may be observed in the white matter. Then the retinal hemorrhages are also common with the carbon monoxide poisoning. Then certain other facts that is important with respect to the carbon monoxide poisoning is that the accidental exposures may occur commonly during the winter month when the indoor braziers angithi is burned in the fire within the large buildings such as hotels and the theaters. As I already talked, in the case of the heater that is being burnt inside the closed room, that may cause the carbon monoxide. Then certain historical suicide cases that occurred due to the carbon monoxide poisoning. There is a long list of the important cases that occurred because of the carbon monoxide poisoning that is a part of your further work and the study related to the carbon monoxide. If you are interested to know it further, you can explore it in the reference materials and over the internet and in the different books. Although most of the carbon monoxide poisoning is definitely accidental, but the suicide, although very uncommon, but in European countries, it was one of the common methods to commit suicide in the older time. Historically, it was prevalent in the Western countries like UK, where the domestic coal gas containing the carbon monoxide was used. Historically, suicide with the carbon monoxide was prevalent in the Western countries like the UK, where the domestic coal gas containing carbon monoxide was once used. Now in the modern time, it has been replaced with the natural gas And so the occurrence of the suicidal intoxication of the carbon monoxide has decreased in the European countries. Also, the importance of the carboxyhemoglobin is that it indicates of the antemortem burn injury. You must be reading in the injuries in case of the burns and in case of head injuries. If the blood that has ejected, EDH blood that has come into the skull, if it is due to the burn, sometimes the EDH is also produced by the burn. If it is due to the burn, then in those cases, it will show the presence of carboxyhemoglobin. If head injury occurred first and the body was burned later, then the blood that has been collected in the EDH space will show the absence of the carboxyhemoglobin. That means that he was killed first and then he was burned. That is to rule out the antemortem burn. This is one of the important point that is related to the carboxyhemoglobin. Then the bruises that are inflicted during the carbon monoxide poisoning also exhibit the cherry red discoloration, different from their normal routine course of their color changes. Before we finish our study on the carbon monoxide, I would like to share some cases with you. This was the case in the last 1 year back. In the Pakistan, at least 21 people died due to the heavy snow that trapped the car in that region. You can see the car was trapped because of heavy snow. There was the long queue of the cars that all got trapped, and basically in that around 21 people died. Although the reason being given were the hypothermia and all those, but another important reason associated with in this case or in the similar type of incidences is that when the exhaust pipe gets blocked, in those cases the carbon monoxide seeps inside the car and the car must have been closed, the heater must have been on, and all those situations might be there. So there is possibility that carbon monoxide inhalation could have been there because they were stuck for more than 1 to 2 days, and that resulted in their death in this case. So this type of awareness is important, that this might also be possible with respect to the car. So by knowledge, we can prevent the many of the casualties like this. Another case of carbon monoxide poisoning in which I performed the autopsy on that person. He was around 70 years old male. He died when he was staying at the 4th floor of the building, and the building was very congested, and the fire took out at the ground floor of the building, and the fumes that got generated got up to that 4th floor, and everything was black in that building, and this was the poorly constructed building, and that he was staying with his 65 years old wife, and she also presented with the similar symptoms, and fortunately his wife was survived in the hospital. And at the autopsy, we were very able to find the cherry red discoloration and all the features of the carbon monoxide poisoning, and it was confirmed later on with the carbon monoxide concentration in the blood by the lab reports that he was died because of the carbon monoxide poisoning. There were no burn injuries on his body, and he expired just by inhaling those fumes that had produced from the burning fire, and that got collected at the top of the building, and that all the building was almost closed from all the sides. That resulted in his death. And in this way, we must be aware about the construction of the buildings, and the ventilation of the house and everything should be taken care in this way, because of the poisonous effect of the gases could be there. So with this, we finish the carbon monoxide. Now we will learn about the cyanide poisoning. Cyanide poisoning was first reported in 1782 by the Swedish pharmacist Carl Wilhelm Scheele while investigating ferric hexacyanoferrate. Cyanide can exist as gas in form of the hydrogen cyanide, liquid as the hydrocyanic acid, or the solid in the white crystalline powder. Its odor is often described as bitter almond odor, but not everyone can detect, as it has certain genetic basis. 20 to 40% of the population are not able to detect the smell of the bitter almond or the cyanide poisoning. In those cases, the chances of the fatality with this is more. Hydrogen cyanide is basically colorless, flammable gas with a faint almond odor, turning yellow or brown as liquid below 26 degrees Celsius. Other forms include the cyanogen, a colorless gas, cyanogen bromide, a crystalline solid, and the cyanogen chloride, a gas or the liquid with the pungent smell. Cyanide salts like the potassium, sodium, calcium are the white in color, non-combustible solids with a faint bitter almond odor. Compounds related to the cyanides include the cyanuric acid, cyanuric chloride and the various other cyanide derivatives. The taste of cyanide is often described as bitter and the burning. You can see color of the cyanide in the liquid form is brownish or yellowish color and it resembles the bitter almond in odor. Then cyanide is used practically for the multiple purposes. In industries, it is used in electroplating and the metal processing, ore extraction, photography, synthetic rubber and the plastic productions. Agriculture sectors, it is used as insecticide, rodenticide and the fumigant pesticides. As a medicine, laterite synthetic amygdaline was once used for the cancer treatment but is now considered ineffective and possibly hazardous. Also, the sodium nitroprusside, that is an antihypertensive agent, but it can cause cyanide toxicity if used excessively. In the laboratories, it is employed in various lab processes. As a household purposes, it is used in fumigation, silver polishing, fertilizers, rodenticides and the insecticides. As a warfare gases, cyanogen compounds, cyanogen bromide, cyanogen chloride, cyanogen iodide, they release the hydrogen cyanide and have been used as a chemical warfare agents. In this way, cyanide is used for various purposes for humans. Then the various sources of the cyanide, they could be from the plants. They are found in the seeds of the plant like the prunus and the malus species. They are produced by the burning like the plastic furniture made of the polyurethane or the polyacrylonitrile, silk or wool, cigarette smoke. Each cigarette releases about 150 to 200 microgram of the hydrogen cyanide. So they are produced by the burning of these plastic furniture, silk or wool and the cigarettes. Then it is produced in the liver from the compounds like the malonitrile and the succinonitrile by their metabolism. The fatal dose of different compounds of the cyanide are: for hydrogen cyanide, breathing in 1 part in 2000 can kill a person instantly. Safe limit is 1 part in the 1 lakhs. Then for hydrocyanic acid, it is 50 to 100 milligrams. Cyanide salts are toxic or fatal at the 100 to 200 milligrams. Potassium or the sodium cyanide are fatal at the dose of 35 milligram per kg. Bitter almonds, that is commonly we eat the bitter almonds, they also contain the cyanide. They have toxicity with the bitter almonds are observed at the 50 to 80 seeds of the almonds. You must have watched certain movies there the criminal might have used this bitter almond to prepare substance or mixing it in the eatables and making their targets kill. So we must know the different sources of the cyanide. Then coming to the toxicokinetics with respect to the cyanide, cyanide is quickly absorbed through the mucous membrane and intact skin, causing systemic toxicity. Ingested cyanide salts release the hydrocyanide in the stomach, which is then absorbed as the cyanide ions and distributed throughout the bloodstream. The liver and the kidney convert the cyanide to the thiocyanate using rhodanase enzyme and the sodium thiosulfate. Thiocyanate is excreted mainly through the urine, but it can accumulate in the kidney, causing the toxicity over there. Cyanide detoxifies by converting to the thiocyanate, binding to the methemoglobin, reacting with the cysteine and integrating with the choline and the methionine. Some become the cyanocobalamin, that is vitamin B12, and the small amount is expelled through the breath and the sweat, giving off a bitter almond smell. The mechanism of action of the cyanide compound is that it causes the histotoxic anoxia, that is cyanide inhibits the cytochrome oxidase enzyme, reducing ATP production, causing tissues to use the anabolic energy production, resulting in the metabolic acidosis that causes production of the lactic acid and leading to the metabolic acidosis. You can see here cyanide, like the carbon monoxide, acts on the electron transport system. It combines with the cytochrome oxidase enzyme in the mitochondria and inhibits the production of ATP. In this way, it causes the toxicity on the body. Also, cyanide is seen to be neurotoxic. It directly damages the nervous system by causing the lipid peroxidation and inhibiting the antioxidant enzymes. It may also activate glutamate receptors in the nervous systems. In this way, the cyanide toxicity are caused. Then the various clinical features seen in case of the cyanide poisoning. In case of the acute poisoning, inhalation leads to the rapid and the severe exposure leading to the immediate coma. Ingestion causes slower onset due to gradual circulation and the liver metabolism. On the central nervous system, the symptoms due to its effect include the anxiety, headache, confusion, convulsions, coma, dilated and the sluggish pupils are the common findings. On the cardiovascular system, initially it causes tachycardia and the hypertension, followed by bradycardia and the hypotension and the ventricular dysrhythmias. On the respiratory system, it begins with the rapid respiratory breathings, progressing to the slow breathing and may lead to the pulmonary edema. Cyanosis usually occurs late, often with the circulatory collapse. Then on the gastrointestinal system, ingestion causes nausea, vomiting, abdominal pain and the potential corrosions. Effects on the skin are seen as the bright red discoloration. As compared to the carbon monoxide poisoning, there was a cherry red discoloration. Here it is the bright red discoloration that is seen on the skin and the mucous membrane due to increased hemoglobin oxygen saturation in the venous blood as a result of the reduced tissue oxygen use. Then cyanide toxicity commonly leads to the metabolic acidosis and the lactic acidosis. Blood gases may indicate the decreased oxygen saturation difference between arteries and the veins. The skin becomes cold and clammy. Cyanosis in case of carbon monoxide poisoning occurs late. Then the features in case of chronic poisoning with the cyanide, the patient presents with the neurological effects like delayed neurological sequelae. Survivors of the acute poisoning may develop Parkinsonian symptoms like echinacea, rigidity, dystonia, dysarthria and the tremors. Imaging often shows the basal ganglia damage. Some patients exhibit personality changes, paranoid psychosis and the memory deficit. On chronic exposure, symptoms may include the headache, vertigo, tremors, weakness, fatigue, dizziness, confusion, hearing changes, motor aphasia, optic neuropathy, seizures, paralysis, myelopathy and permanent mental impairment. These clinical features must be known, as not necessarily the patient will present with all the features, but some of the features might be there. So correlating all the features, we may suspect of the cyanide poisoning. Specific chronic effects are seen as a tobacco amblyopia. Visual loss is prevalent in the heavy smokers. Stopping of the smoking and using hydroxycobalamin may help in such patients. Then the Leber's hereditary optic atrophy is also seen in the case of the cyanide poisoning. It affects male due to the congenital rhodanase deficiency. They are not able to metabolize the cyanide enzyme, leading to acute visual failures. Hydroxycobalamin may be beneficial in these patients. Then the tropical ataxic neuropathy is also seen among the patients, common among the cassava consumers, causing sensory neuropathy, optic atrophy, ataxia, deafness, glossitis, stomatitis and the scrotal dermatitis. Conjo from the improperly processed cassavas causes the spastic paraparesis. Then the other health effect due to the chronic cyanide poisoning include the nosebleeds and the cyanide rash with itching and the skin eruptions. Workers exposed to the cyanide solution may develop enlarged thyroid glands and abnormal thyroid function. Eye exposure causes pain, blepharospasm, lacrimation, conjunctivitis, palpebral edema and the photophobia. Cyanogen severely irritates eyes and the respiratory tracts. On the pregnancy, although we have the limited human data, but on the animal studies, it has been found that it is embryotoxic and teratogenic effect. Antidote for the maternal poisoning should not be withheld due to the pregnancy concern. Enhanced fetal monitoring may be necessary after the cyanide exposure, particularly in case of the pregnancy. Enhanced fetal monitoring may be necessary after the cyanide exposure. Then the diagnostic test for the cyanide poisonings includes the Lee-Jones test, that is mix the ferrous sulfate crystals with the gastric aspirate and add sodium hydroxide and the hydrochloric acid. If it shows greenish blue color, then it indicates the cyanide. Purplish color indicates the salicylate poisoning. This is the bedside test for the cyanide and the salicylate toxicity. Then the serum cyanide level is the important for the diagnosis. It confirms the poisoning. Normal blood concentration of the cyanide is less than 0.004 microgram per ml for the non-smokers and 0.006 microgram per ml for the smokers. The lab investigation that may be suggestive of the cyanide poisoning include the CBC, blood gases, electrolyte, lactate, renal function test, chest X-ray, whole blood cyanide level. Clinical signs that are indicative of the cyanide poisoning are the serum lactate level of more than 7 to 10 millimole per liter, elevated anion gap, abnormal arterial blood gases, high venous oxygen saturation. ECG will show the erratic cardiac rhythms, atrioventricular block, asystole may also occur rarely, STT segmented changes may also occur in case of the cyanide poisoning. All these features may help in making the diagnosis of the cyanide poisoning. So this is all for today. We will continue in the next class. Thank you.